Pharmac has dealt, I think, primarily with an enormous influx of money, which it has turned into medicines. If there's one thing that people at Pharmac really like, it is buying medicines for New Zealanders, and they've been doing a huge amount of that. 83 new listings or widened access funding investments in the 2024-2025 year, 31 of that being new listings and 52 widening access to more New Zealanders. A total 4.1 million New Zealanders received either funded medicines, devices or related products, and in the coming year we're going to have a combined pharmaceutical budget of 1.76 billion, which is a record by any standard, and a product, first of all, of filling in quite a significant fiscal hole or cliff that we inherited, and then putting a very large amounts of additional money in order to satisfy the government's stated goals of increasing the number of cancer medicines, a total, as I say, of 64 new medicines have been funded, 33 of those cancer and 31 non-cancer since June 2024 when that uplift took place, and the uplift will see around about 200,000 New Zealanders benefit. Besides that, we are investing in an upgrade to information technology, which I think is long overdue, and we're doing considerable work to improve the culture of Pharmac, and I will wind up just after referring to two I think quite significant events that have occurred recently. One is the change in the estradiol patch. These hormone replacement therapy patches became first a source of controversy because of global shortages, but then because the patches that were initially proposed to be funded were ones that a lot of the users found uncomfortable. Pharmac really is listening now, whereas once it might have had a reputation for being quite calcified. It has actually listened to the patients and is now going to fund an alternative so that people will have more variety. A very similar thing happened around insulin pumps. There was a decision to fund a certain type of insulin pump. There's a lot of very negative feedback about that. And so we decided, or at least Pharmac decided, in line with the new direction to be more responsive to patient concerns, that they'd go back to the drawing board, and again they've made an alternative available. So I think that's quite a big shift in Pharmac's culture, and we're certainly seeing from patients, clinicians and vendors alike that they feel that Pharmac is now a lot more receptive, and I think a lot of that goes to the cultural change that our chair and our acting chief executive are driving, so I thank them for that.
Thank you.
Thank you, Minister, and thank you for the tradition you've established with this committee of turning up and answering questions. We really appreciate it.
Thank you.
Is it correct that from 1 July, publicly funded cancer medicines will be funded for patients in private healthcare for the 12 months from the date of each medicine being funded?
Yes, that's correct. So if a new medicine is funded, we don't want a person who had commenced their treatment in a private setting to have to transfer to a public setting in order to get the benefit of the public funding. They're taxpayers, they paid for it. If it's publicly funded for someone with their condition, they should get the benefit of that. And when someone's undergoing cancer care, as I'm sure you know better than anyone being a doctor, you know, it's very disruptive to have to change the location, potentially change the oncologist. So we're now going to make sure that they have a seamless experience.
Insurance will cover medicines funded by Pharmac, and most people receiving private cancer care have insurance, the vast majority. Why did you introduce this change that will mostly subsidise insurance companies, minimal improvement in access to the public?
Well, first of all, you have to look at an insurance company's financial statements. The first thing you notice is that all of their revenue comes from the premiums which are paid by their clients. Those clients are also New Zealand taxpayers, and I believe that if they've paid their taxes, they have the rights of New Zealand citizens, they should not be disadvantaged by the fact that they have taken the precaution of having private insurance. What's more, they would be able to access the Pharmac funded medicines if they were to do it in a public hospital. The only difference we have made is that they don't have to inconveniently change hospitals in order to get the public benefits to which they're entitled.
Can I just describe that a number of new medicines, 12 or 13 have been introduced, new cancer medicines, and over the last year, and those people will have transferred to the private system for their treatment. So it appears to have occurred without that much disruption. So what is the problem you're trying to fix?
Well, first of all, I just, our chair I think might have wanted to say something.
Oh, well, I could answer that as well, but they will still have to pay for the administration of the medicine, sorry, so just so that you're clear about that. So we're paying for the medicine, but if it's, So
Yeah.
that's where, but
Yeah.
like you still got,
The patient, they would, currently what happens is that when a new medicine is funded by Pharmac, that becomes funded by their insurance. The patient is no better off from this change, except for the site where the care is occurring for a period of 12 months.
Yeah.
So this money that you're spending on this is achieving almost nothing in terms of it is just a subsidy in private insurance.
No, I completely disagree. First of all, I would not minimise the inconvenience of a person having to change their arrangement in the middle of a course of cancer treatment. That is, I mean, when you're getting treated for cancer, you just don't want any more problems in your life, no more inconveniences. You just want to get through it, or at least that's what I've observed in people that have gone through that. The second thing is you can argue that it's a subsidy for insurers, but actually insurers don't have any money other than what's paid to them by the patients. So ultimately, this is a subsidy for the patients who are also taxpayers who are entitled to public funding in this country.
can I just also add that we had correspondence from people who were certainly in private care and had insurance, and then we'd funded one of those medicines in the last 12 months, and they were eligible for 4 treatments, and actually they needed 12. So to receive the other 8, they were going to have to move into the public system, and that was very much him saying that he has been, he's tried a number of different treatments, he's now doing this one. The thought of having to change an oncologist and just to get access to those extra 8 treatments that he desperately needs was incredibly stressful.
The vast majority of New Zealanders do not have private insurance. Wouldn't this money have been better spent on hiring oncologists in the public system so that people can get free care there?
Well, I just disagree. I think you can always say we could do more if we were prepared to exclude some New Zealanders from the benefits of a program.
Frankly, we received documents from your office which makes it clear that you prepared to announce this policy in April, but then no announcement was made. Why didn't you make this change public?
Well, again, I don't recall why I did or didn't announce it. Generally, pretty keen to announce anything that is happening in my portfolio that's good. There's no reason that I can think of. I can come back to you if you'd like, but I can't think why that would be. Yeah.
Sorry if I'm
What was that, sorry?
Point of order.
Point of order.
I may be mistaken, but is that an act label you're wearing on your coat? Because I understand under the rules that you're not allowed to wear.
You know what? If it would make you happier, I'm very happy to take the pin off. No problem. I look forward to discussing that principle with you in other forums.
Thank you, Minister. How has Pharmac delivered value from the investment put into it, which is now a record investment?
Well, we have funded a vast number of additional medicines, 64 new medicines, 33 of them being for cancer, 31 not being for things other than cancer. And for the people who are in those positions, it's not really for me to say, other than, first of all, it can save your life. It's just an enormously positive thing. And look, it's not me that's done it, it's the taxpayer, and to some extent this government that's done it, but it has literally saved people's lives. And there's a total of 200,000 New Zealanders who in some way have got a medicine, cancer or non-cancer, that they wouldn't not have got had it not been for this uplift in funding.
Right, and this is nothing, how many new medications have we funded?
Total of 64.
That's from that additional funding that came from the government. But I think it's also to prove that that Pharmac model in some respects does work, is that they've then also done about another 19 medicines on top of it as their business for usual, if you like, where they're making money savings and able to fund. So overall for the whole year there were 83. Of them, 64 were from the new funding, the 604 million. And the other 19 is them negotiating, getting a better deal and doing what they do.
So just to be clear, Pharmac is continuously trying to get a better deal. And, you know, they do their best work making sure that if there's been a price drop somewhere in the world, they're there to make sure that that discount is gained by New Zealand patients. Last year, or at least from the 2023 to 2024 year, they managed to save $162 million that they would have otherwise had to spend, basically by shopping around for a better deal. They do that continuously. That's $162 million of extra medicines that we now have.
Thank you. Jenny?
Oh, thank you very much. Previously, we've talked about measuring broader health and economic benefits relating to, you know, more medicines flowing through to patients. Where's that piece of work at?
Yeah, so this is something that I'm personally really excited about. Well, first of all, answer your question. Where it's up to is we've had expert advice by a professor out of the Netherlands. He's provided a report that is informing the way that Pharmac goes about making its budget bids. Budget bids are a pretty tough business, so we didn't secure additional funding in the budget this year, but we're indefatigable. We're indefatigable, and we'll keep using this intelligence that we've been able to procure to make the case that if the government gives more money to Pharmac, then it will be able to fund more medicines, and those will actually save money elsewhere. So we're obviously really excited about this, and I believe in the long term, Pharmac's role will be to advocate for more use of technology, not just medicines but also devices, and say if we had more technology in the healthcare system, then the people who are very valuable, but you know, there's never going to be enough people in healthcare. We need to use technology to make the people more effective at caring for the patients. So that's very much part of our agenda. We've had the work done. We didn't get the money we hoped for in the budget this year. We accept that because, frankly, we've had so much lately. But you know, we're never going to give up.
Could I perhaps jump in there, Minister? In addition to that, we recognise we have a team of health economists that obviously do the analysis. Because it's a relatively new and emerging area, we have to upskill. So we're putting time and effort off the back of the work with the Netherlands, train up, build more capability, so that as we do head forward potentially into Budget 26, our ability to deliver that in a robust way is enhanced.
So you're providing for you a greater sort of backstory for a budget bid.
Yeah,
To back it up.
more evidence based on some potential real scenarios with a couple of areas of health need. That's the intention.
I mean, the world's kind of talking about obesity and the effects of that, and then of course you're seeing you know, very different treatments coming through, and the effects that can have on people's whole livelihoods from a societal impacts, but equally from a health. You know, it's really interesting, and as I say, whenever you're on any of the forums, which we occasionally are, you know, via online, you can just see that's very much the talk of the world from a health perspective as to how you use, you know, continuously use expensive, but you'd be money saving in the end.
Just now you mentioned in your opening remarks that you changed the culture of Pharmac to try to listen to patients a bit more. So through what channel you actually receive those feedback right now?
So we've done quite an extensive program. There's been an external reviewer who has gone into Pharmac, talked to a lot of people, come up with some conclusions that are confronting for some people, but the change is happening. Our new chief executive, I think, will make a very big difference, as has our acting chief executive, and really this change has been driven very strongly by our chair. Previously there have been patient forums, but the feedback that I'm getting from people involved in the medicines industry, the clinicians and the patient groups, is they're finding that when they go along to these sessions now with Pharmac, that they're getting listened to a lot more intently, and they're getting real change out of the way that Pharmac operates. So I wouldn't say that we've changed the structure of what we do, but I think we have changed the sincerity and the effectiveness of it, and Paula might like to add.
Yeah, well, it's really exciting. So at the moment we're setting up a consumer workshop, and so they're electing their own chairperson of that group. That group will have 8 to 10 people on it, and as a consequence of that, they will be actively involved. No, it's not just hey, we're thinking about doing this medicine. It's the HTA process that we're using. They will be getting actively involved in the changes and the transformation that was already started within Pharmac, but seeing how that rolls out. And and fast tracking some lower risk medicines and how we might do that.
So is there any example of those
Give the give the opposition a run.
So is there any example that those patient voices or feedback actually changing the decision of Pharmac?
Oh, very much so. And I mean, the Minister gave 2 great examples. Those 2 are where we might have slightly got it wrong. And we've got some real challenges with supply and for outside of our control, if you like, for a variety of reasons worldwide. And so how we then, ADHD medicines are one that's, controversial at the moment. So replacing that so that people get the kind of, but it can be quite confronting to have to change your medication that's actually working for you.
Minister, I hope you can make a better job with this question than earlier on in the hearing of another minister. The government has invested $600 million into cancer medicines over 4 years. How are you tracking the impact of that on cancer survival?
Look, that's not something that I can give you an answer to in numbers. However, what we do know is that Pharmac's objective is to ensure that what we pick as the next medicine off, or the next cab off the rank, is going to be the optimal cancer survival or extension and quality adjusted life years. So I think we can be quite confident that we're getting the best bang for buck, as Pharmac always have. And bear in mind that we haven't reserved funding only for cancer survival. We've actually put those cancer medicines up against non-cancer medicines according to the same measures. So I guess it would be nice to think that we had a bespoke assessment of this funding. But for my money, where we're at with Pharmac is that we are still not spending anything like the OECD average for share of the health budget on medicines, and we've got some distance to go.
Government collects the raw data required to measure cancer survival, measures cancer mortality, which is a different thing. $600 million, much of it for cancer medicines. Say you're concerned about outcomes, why don't you report cancer survival?
Well, again, I think where we're up to, I'm speaking purely for Pharmac, and all I know is that Pharmac is always picking the best quality adjusted life year outcome for each extra dollar that it gets, and I believe that we could spend a lot more money before we get to the point that we're getting diminishing returns. And I also make the point that we're trading off cancer survival against all of the other objectives that we have with medicine. So, you can argue there should be a bespoke measure. However, it's good enough for me that we're always buying the highest value for money with each extra dollar that we get. And I believe we've got a lot further to go before we've spent too much on medicines in this country.
Budget gets substantially less after double-digit increases under both governments, 4%, 2%, 0% the out years. What headroom is there for new purchases in the in the current coming financial years, either from the uplift or from savings?
Well, first of all, the uplift will be subject to future budgets, and as we've discussed, we're certainly prepared to argue for more funding for medicines and devices by making the case that this will make healthcare more productive and save the government money elsewhere. So that's underway, and that'll be subject to another budget bid process. In terms of savings, obviously that depends on market conditions. In a prior year we saved 162 million, so that's about 10% uplift, just through greater efficiency. And then there's the question of, notwithstanding savings or the new initiative we have to argue for a whole of society benefits, if the government has good fiscal conditions, then hopefully we'll put even more money in.
And finally, Minister, I'm aware this wasn't a commitment you made, but other parties in government made a commitment to patients with blood cancer that hasn't been able to be upheld through this initiative. Do you see an opportunity to address that outcome, which has been very unfair for those patients whose medicines were not included in the cancer medicine initiative?
Look, I get letters from people every day affected by blood cancers. I've had people very dear to me who have been lost to blood cancers. So I can't stress enough that funding medicines for blood cancers is one of the most important things we can be doing. I also have to say that I will never support a world where a politician chooses which medicines get funded, no matter how strongly I feel about it. My job is to leave the experts who do the assessments based on the value for money for the whole of the New Zealand population to make those decisions. My job is to advocate to get more money for Pharmac. I think I've done a pretty good job so far. I think we've got more than anyone ever thought we could get, but I'm going to have to sharpen my pencil and keep trying to get them more money so that I can write some better responses to those letters.
Thank you, Mr. Chair. Minister, what consideration did you give to the potential impact on Māori health outcomes when directing Pharmac to stop embedding TTT or Waitangi in operation?
The same consideration that I give to European, Asian, Pacific Island, Middle East, African, same consideration as every single human being who calls this country home and has a right to pharmaceuticals under this agency.
Do you believe that it's appropriate to direct Crown Agency to deprioritise TTT or Waitangi, considering the legal obligations outlined in payroll, as well as the government policy statement that helps?
Well, the treaty's a 185-year-old piece of paper. I'm interested in getting the best health technology assessments, buying the best medicines, and extending people's lives the best we can, regardless of whether their ancestors got here 800 years ago, like some of mine, or just got off the plane at Auckland International this morning. We all have equal human rights.
And so what evidence did you base your decision to direct operations to remove TTT or Waitangi from operation?
The fact that every single human being is alike in dignity.
And in terms of Te Rautaki Whai Oranga, does that still exist within the organisation?
I will refer any management decisions to the Chief Executive.
We know that there's been a disestablishment of the Māori Health Directorate. Is this a result of deprioritising Māori health outcomes?
Well, no, because we haven't deprioritised Māori health outcomes. We prioritise all New Zealanders' health outcomes equally.
And so when we think about the 7 to 8 year difference in life expectancy for Māori, do you think that by moving Te Tīki or Waitangi to the side, that the agency is still focused on improving Māori health outcomes?
Well, absolutely, but I just make the point that some of us are Māori and we don't feel disadvantaged. There are many reasons why people have different life outcomes, and to simply lazily group people by their ethnicity is not only an ineffective way of prioritising people, it is also divisive, and that's why this government has issued a cabinet circular that all services should be delivered on the basis of need, not race. And you have to ask yourself, if you're prepared to go down the track of lazily grouping people by their ancestry, are you really prepared to accept all of the consequences of doing that? Because if you really start thinking through it, if you're prepared to say that somebody's outcomes are an artifact of their ethnicity or their ancestry, then presumably that is good outcomes and bad outcomes. And presumably, if you are going to allow positive discrimination against a group of people based on their race to try and compensate for bad outcomes, you imagine, then you would have to be prepared to sanction negative outcomes against a person based on race.
If Māori are going 7 to 8 years earlier than non-Māori, should that not be a focus for Pharmac? And how is Pharmac going to improve Māori health outcomes? If Te Reo Tiki Whauranga is not a priority.
Well, I've addressed your question, and what I'd recommend is that you rewatch the tape and hopefully get it the second time.
Questions for Angus?
You've indicated work on a medicine strategy is underway. How will that strategy work?
Sorry, the medicine strategy? Well, as you know, there's quite a number of objectives throughout the strategy, and we intend to implement them one by one. I can go to a more specific one if you'd like, but yeah.
You have work underway on medical devices and minimum expectation. Can you update on what is that?
Yeah, absolutely. So as far as medical devices goes, going back to 2012, I believe there's been ambiguity about whether the correct role of Pharmac or Health New Zealand, previously the DHBs, was to be the assessor and procurer of medical devices. I think it's fair to say I would like to see that ambiguity gone and Pharmac either in charge of devices or not. That's an ongoing discussion between myself and Minister Brown. There's been some work by the Ministry of Health advising us on that. At this point, we're not really that happy with the advice. I don't think they've got to the nub of the issue. But my commitment is to, well, at least by the end of the term, I hope by the end of this year, to have decided, is it Pharmac or is it Health New Zealand or is it someone else that does devices? And my preference is that Pharmac should do it for the simple reason that I want to see Pharmac as an advocate for health technology within healthcare, and I want to see Pharmac as, I guess, the organisation that is most efficacious at assessing technologies and doing procurement.
How about Hamish and come back?
Sure.
We've got 2 minutes left.
So there's an increasing amount of innovation in the medical space. What changes, if any, is Pharmac doing to keep up?
Well, I mean, you know, I don't know that we're doing anything different. We just know that there is so much coming at us. If you look at the graph of cancer treatments being invented, it's not going like that. It's not going like that. It's actually going like that. It's accelerating exponentially. And that means that we need to continue working as fast as we can. We're upgrading our software. We're putting $7 million into that because they had quite clunky systems. But ultimately, it's not really a matter of doing something differently. It's just being prepared to do it better and faster.
This question very well. Both governments have found the Cancer Agency's assessment of medicines, which you'll correctly describe as an overwhelming number of new medicines in the cancer, for cancer. Both governments have found that helpful. Does the government have a plan to continue that high COP assessment, which I've described as having an element of international comparison about what's funded and a lens in terms of its clinical impact?
Look, I think what we really need to be doing is, first of all, sticking to the Pharmac model. I'm completely committed to an arm's length, data-driven, science-based entity run by an independent chair with a chief executive, distance from the minister or politics, making the decisions. The next point is, yes, there will be the Cancer Control Agency, yes, there will be other countries that will have their own assessments, but our job is to ensure that this entity is as efficient as possible, listens well, makes fast decisions, and has as much cash hosed in the back end as the taxpayer is prepared to put up, and my job is to advocate for that.